Okay, welcome to Researching Happy. This is the podcast all about the mental health and wellbeing world. We want to hear about the stories behind the studies of wellbeing science and hear from world-leading experts from around the world. And so here we are. We have Professor Claudia Trudel-Fitzgerald. Welcome to the show, Claudia.
Thank you so much for having me, Matt.
Yeah, I'm really excited for this conversation. Our research, we've just met, but our research has some overlap and similarities, which is great. I've got a very brief bio about you that I'll quickly read, if that's okay.
Sure.
Cool. So, Dr. Claudia Fitzgerald, or Professor Claudia Trudel-Fitzgerald, investigates psychological, social, and behavioral determinants of age-related disease, healthy aging, and longevity at the University of Quebec. Her work seeks to unravel both positive and negative factors that impact physical health and disease risk in diverse populations. She is the UQTR Research Chair in Social Disparities, Stress-Related Coping and Health, and is also a clinical psychologist trained in cognitive behavioral therapy with experience in treating anxiety, depression, and insomnia across adulthood. So welcome to the show.
Thank you.
So tell us about yourself. You're in Quebec. Tell us a little bit about yourself.
Yes, so I'm originally from Quebec, the province of Quebec in Canada, so you can probably hear that from my accent. Although I spent many years in the US and in Boston more specifically. So I guess I'll just go with the story. You said you like stories. So here's a first story. The story of how I got into the positive psych science, because I'm trained as a clinical psychologist, as I mentioned, in Quebec City, Canada. So I was really interested in, psychological distress, psychopathology, essentially everything that is not going really well in the human experience. So I was really not into the happiness science from the get-go. And I did my thesis during my PhD in psycho-oncology. So I was really interested in how people cope with cancer. So once they get their diagnosis, how are they doing in terms of like anxiety, depression, sleep difficulties? And that was really my graduate research. But at the same time, I was doing clinical work with this population. And one of the recurring questions was, does stress cause cancer? And back in the days, it's a couple of years ago already, but the evidence on that research question was kind of all over the place. So we saw some association, other research was showing no results. And I was personally also interested or intrigued by that research question. So I decided to do a postdoc on this. And then I moved to a public health school at Harvard School of Public Health to have access to like really long data where people were follow up for many decades and, got trained by really strong epidemiologists, folks that are really interested in like the methods for causal inference. So that was a totally different brain than my clinical psychologist brain. But I was still in that space, essentially looking at whether stress would cause cancer or influence cancer survival over time. So at that point, you're just like, where is the happiness part in this? The happiness part got in because my mentor for my postdoc was interested in the role or the potential contribution of psychological well-being in future health outcomes over time.
Yeah.
So by joining our lab, I got kind of pulled in those research projects. But I have to say, like, at first I was a little bit naive. I was just like, okay, happiness. I mean, it's kind of exciting. Everybody is pursuing happiness, but is there anything really beyond just the absence of distress? This classical sentence that we read in paper. I was having this question myself before getting into the field. And so I started to do a couple of different projects looking at whether, optimism or emotional vitality was associated with blood pressure. That was my first project in that space. And then I stayed there as a postdoc for a couple of years. And then I got promoted to a research scientist in 2018. So that's kind of the non-tenure track faculty position at Harvard when they opened the Center for Health and Happiness back then. So I got really more involved into like positive psychology projects and science. And one of the focus of that center was also to look at measurement, which is a really hot topic. So I got pulled into the measurement space and really, I'm kind of kidding when I'm saying like pulled in because I was really interested and really enjoyed discovering more that part of the human functioning essentially. And now I'm really convinced that it's more than just the absence of distress.
Yeah, very cool. And I'm learning that we have even probably more overlap than even what I thought. So who was your mentor, just quickly?
Yeah, Laura Kubczynski.
Oh, wow, cool.
Yeah, so she was the co-founding director of the Center for Health and Happiness in around 2017, 2018, around those
Wow.
years.
Yeah. I mean, I'm having that. Obviously, I don't know her, but I just see her name come up everywhere, like absolutely
Mm-hmm.
everywhere. That's really
She's
cool.
great.
Yeah, very cool. So, just on, I imagine this is from your PhD times, but I don't know, I guess. But I was just looking through some of your papers, and this one was from 2013. And it says, the title of it is "Which Symptoms Come First? Exploration of the Temporal Relationships Between Cancer-Related Symptoms Over an 18-Month Period." I think that it was such an interesting paper, this idea of actually tracking over time what comes first. And
Mm-hmm.
it did make me think, like, we always talk about this link between, mental well-being, low levels of well-being, languishing, leading to future mental illness. And I think that's a black box that no one really has looked at very much, of basically, like you say, which symptoms come first? How does it go from the absence of well-being into the presence of mental illness? So that's a shout out for if someone wants to figure out how to do that. I think you might have a methodology there that's useful.
Yeah, that was actually one of my three thesis paper, and probably the more geeky or the more method-y. I did my PhD with José Savard at Laval University in Quebec, and it was all on the bad stuff. Like, this is when I was looking at how people with cancer cope with their disease, but really we used several time points to look at which symptoms were more predictive of each other over time to get intervention targets. So you want to intervene earlier rather than later and try to prevent the development or the aggravation of other symptoms over time. And I think so. I was already kind of intrigued by this causal inference piece, or this kind of temporality, so which is the precursor of any other subsequent symptoms. And that was still like all kind of mental health related symptoms, but down the road, yeah, physical health is also interesting to look at.
Very cool. And I've said a few times recently that my goal of the podcast is for someone to cite an episode of the podcast in one of their papers to say, I got the idea from listening to the podcast. So I'm just going to throw that out there if someone wants to do that. Claudia's got the method written down. Do the same thing for understanding how languishing goes to mental illness.
Yeah, and then we can put your podcast in the acknowledgement section of the
Yeah,
paper.
exactly. Very cool. All right. So, for people who, oh, hey, and you just won an award at the IPA conference as well. So why don't you tell us about what the award was for?
Yes, well, thank you. So this is really, I'm really proud about this, and at the same time really humble, because it's an international society. There are so many people doing amazing work in the positive psychology space. So this is the Early Career Award. So people who finished their PhD within the last 10 years roughly, and then contributed in a substantive manner to the science of happiness and well-being, and more broadly. So I think I presented in the application my work on measurement, trying to disentangle, the different dimensions, how we measure them. There has been a lot of super important work in the psychology science, but having been in the more like public health space and epidemiology space over the past few years, I think it brings a slightly different, and I would say complementary, perspective of what has been done in psychology. And otherwise, my work has been mainly focused on using different dimensions of psychological well-being to think about them as predictor of future physical health outcomes. And I think the argument here is so interesting because, like, I'm as a clinical psychologist, you don't need to convince me that mental health is important. But I think for some public health leaders and, people who make decisions from a population-based perspective, sometimes you need to bring the physical health argument in there to convince them. So if the science actually is building up, increasingly showing that mental health not only predict like mental health later on, but also predict physical health over time. And now it's really showing that you need to take care of that. And I think the pandemic, that as a side note, was an unfortunate experience, but really highlighted the importance of mental health. But I think another way is by showing its predictive value for physical health, longevity over time. So I've been working in that space, trying to show the protective role of, different dimensions of psychological well-being in relation to physical health.
Yeah.
So that has been a lot of my work, and then increasingly moving towards like mechanisms of resilience. But I think we can speak about that later. But essentially for the decade I've been conducting for the past 10 years, and I'm always happy, and I feel like I really need to highlight the work of my colleagues because, it takes a village, and I'm taking the prize, but at the same time, none of this would have been possible without colleagues and mentors. So I share this award with them.
Very cool. All right, awesome. Very gracious in your award. That's very cool. And you I just agree with everything you're saying. Basically, like I think from our perspective, the work that we do here in Australia, we are often trying to convince people basically about well-being. That's kind of, I feel like that's our job here, is trying to convince organizations, government, policy. And I do think that, like you say, the longevity research and the physical health research is the most compelling. Because at the end of the day, I think tying, we talk about the value of subjective experiences, but tying that to language that government speaks, which is their, metrics like longevity, like QALYs, like, financial savings, these sorts of things, is just so valuable. And having these as like tools for advocacy, I think just really helps our mission, basically.
Mm-hmm.
So going into this a little bit, your research, as you said, highlights how these different aspects of psychological well-being, like optimism, like life satisfaction, can predict long-term physical health outcomes. What is the most compelling evidence that you've found, either in your research or research from around the place, that can link these factors to health?
Yeah, I have a few of them that I can share. And I like the fact that you said your research or anything in this space, because when I'll say we found that, I'll mean our team, but also like everybody who's devoted to this topic. But one of the key kind of finding of this work is that the most consistent association that we see when we look at different dimensions of psychological well-being is the association with cardiovascular health and mortality longevity outcomes. So it seems like there is really something that is potentially predictive in a causal way with these health outcomes, which is really interesting from the clinical perspective, but also intervention and more like population-based strategies that we can think of. What's interesting with that point is that when we look at cancer outcomes, the association is not as clear as with CVD or with mortality. And I think part of it is related to methodological issues. And I'll give one example of that, is that oftentimes in studies, we will combine the cancer site just to have enough statistical power. But all the different cancer sites actually are different diseases.
Yeah,
so they have
yeah,
different
exactly.
risk factors. So when you combine all of them, essentially it's a fruit salad. It's a combination of different things. You have a little bit of noise in there. So if we don't see association, is it because really well-being is not predictive of cancer outcome? Or is it because you're just looking at different things altogether? And really the ideal scenario is to look at cancer sites separately. And I would suspect that there might be some association for certain cancer and not for others, because some are more sensitive to like the more behavioral risk factors and psychological risk factors, whereas there are other cancer sites where we don't see that traction as much with these kinds of with factors. So I would say this is the first key point of this literature, is that we see really the predictive value of well-being with cardiovascular outcomes and longevity mortality.
And is that, I'm assuming, controlled for things like social economic status?
Yeah, so you're kind of reading my mind, because that was my second
Okay,
point.
cool.
Like what we adjust for or control for in the statistical analyses, we will control for like the usual suspects. So when we see these associations, typically it's beyond age, sex, education level, everything under the sun that we have access in these large database and cohorts. So that's really interesting to see that over and above these factors, and typically we control for health status, so like BMI, blood pressure, we do see associations of different dimensions of psychological well-being with these outcomes of physical health. What we do also in this body of work is that we control for depressive symptoms. So if we see an association, it means that it exists regardless or independently from if people are depressed or anxious, like we take the distress measure that we have access to. And I think that's really interesting from the clinical perspective first, because it says, even if you're anxious, even if you're depressed to a certain level, if you're more optimistic or you have stronger purpose in life, like the reason why you get up in the morning and do your activities, it seems like it could be protective for future health outcomes over time. So I think it's really stimulating, and is not the good word my French brain is looking now, but it's really encouraging even for people who are experiencing clinical psychopathology or like non-clinical symptoms of psychological distress. So that's kind of another thing that is interesting. And for what it's worth, as one of my colleagues say, never in the distress literature they adjust for happiness or they control for happiness. So we're doing this, but they don't do it in the other space. But that's kind of just a side note, a little geeky side note.
Yeah, interesting.
Yeah. And maybe the third point that I could bring to this body of work is that we're getting better at understanding what are the underlying mechanisms. So, if life satisfaction, purpose in life, optimism are predictive of long-term health outcomes, longevity, reduced risk of cardiovascular diseases, how does that work? Like, what's the mechanism underlying this? And there are pretty good evidence with lifestyle factors, so health behaviors. And I'm thinking as much the good ones, like people are more active physically, they sleep better, they tend to eat better, but also the bad behavior. So they're less likely to smoke, to have heavy alcohol drinking. So we see these associations with different dimensions of psychological well-being. And interestingly, sometimes, or I'll say oftentimes, we see a dose-response relationship, meaning that you don't have necessarily to have a really high level of psychological well-being to see the association with those health behaviors. So in other words, even when people have a moderate level of happiness or a moderate level of optimism, it seems like it's still associated with better lifestyle factors. We have looked a little bit with biological processes. For this, it's a little bit more mixed evidence. So we see, for instance, association with like blood pressure, glucose, lipids. So everything that is going on under the skin and that we know over time influence those health outcomes. There were a couple of studies made by the research team where I was, where we looked at telomere length, and it's not clearly associated with at least optimism and certain dimensions of psychological well-being. So we're kind of still working in that space and trying to understand if those facets of psychological well-being really go under the skin and influence long-term health outcomes. How does it work from the biological standpoint?
There's a lot there, and that's just so interesting. Thank you. And it's, I guess the question is like, why should we care? You know, I think I like hearing people that have come from one world and gone into another. So you know you've come from a clinical world and you've gone into an epidemiology world, but I'm sure you still bring many of the perspective of a clinician into your work.
Mm-hmm.
So my question, I guess, in terms of why should we care, is it about identifying like new targets? Is that how what do you think are the implications of this research, other than, you know, I said that we can advocate and say that well-being is this valuable thing because it's associated with possibly causally with longevity? Why else should we care?
Yeah, I think the advocacy part is a fair one on its own. I think otherwise I'm thinking about it in terms of like bringing some form of control and empowerment to people. And I have another anecdote about this where among clinicians, sometimes there is the concern, and it's a really valuable concern, that this body of research will bring guilt to individuals who end up developing those diseases, because they can think, well, I was not like happy enough, I was too depressed, I was not optimistic enough. And really, each time I'm talking with clinicians or even when I teach, I bring this idea back saying that's really not the goal. The goal is not to make people feel guilty. The goal is really to think about what are the different risk factors for a given condition, and what are the risk factors that we can intervene on, and what are the ones that we cannot change anything about it. Like for now, maybe it will change in the future, but we cannot change the gene. Like if I have the genetics of like breast cancer, there's not that much that I can do about this. But if I have a range of other factors that I can intervene on and try my best to like have good health behaviors, good mental health, and that can contribute to lowering my risk. I think that's kind of the interesting piece of thinking about psychological factors as risk factor for long-term health outcomes. So kind of bringing control and empowerment to people without, of course, inducing any guilt or feeling of responsibility or
Yeah. And yeah, I ask, I guess, because we've got a project happening at the moment supporting the psychological needs of people living with a cancer called multiple myeloma.
Mm-hmm.
And we've done a lot of consumer engagement so far. We've put people through, we've got like a wellbeing program that we deliver and we test, and we've put about people through the program just as it is, unmodified, as basically as a consumer engagement. Because what we're finding, and this speaks to what we'll talk about in a minute about wellbeing measurement, but when we say wellbeing in the cancer space, they don't mean anything like what we mean. They're talking about symptom management, recovery, these kinds of ideas, all valuable stuff, but just different to what we're talking about. And it's been quite interesting that because, and I don't know whether it's this particular cancer, I'm not sure, but it's, for people who haven't heard me talk about it before, it's this idea that it's an incurable cancer, which means that basically people, their life expectancy, I think, is within sort of 5 to 10 years of diagnosis, but they're on treatment for that whole time. And there's a lot of uncertainty in terms of which treatment will work. That's quite experimental, and some people have an experience where their first treatment is just fine, and then others will go up and down, and things work until they stop working, and then you try the next thing. But talking about these concepts of optimism, meaning, and purpose, I think we have a PhD student working on the project who's doing an awesome job, and she's trying to explore the unmet needs, basically, of this population cohort. And the sort of like the spiritual / psychological needs, I think, are coming up as some of the greatest needs of what do I want out of life, And so I think having this type of evidence around the, meaning and purpose, optimism, how these things can be useful for physical health, even if that's just maximizing, the health that we have left, I think is just so valuable. And it's something that, at least in the Australian context, we're seeing is not part of the conversation really that they're having with their health professionals.
Yeah, because they have so many things to care about,
Yeah,
like
exactly.
medically and in terms of like symptoms management. But like, just I was listening to you and thinking back of when I was doing clinical work with cancer at large, not necessarily with this specific cancer site, but like, even if they have to handle all of this on a daily basis, they can still aim for or seek hedonic and eudaimonic well-being, right? Like they can seek happiness on a daily basis, or like positive emotion on a daily basis despite all the symptoms. And even if they don't have a really good prognosis as they move along, they can be really prompt to think about like, well, what is my purpose in life for the time that is left? What was my purpose in life? If you think about the different exercise you can do for mastery, like the sense of mastery on your own life, which is one of the well-being dimension, it's really like thinking back of what you've done and what you've accomplished and what's going to be left after you're gone. So I think these are all really key construct and things that people care about, but it's just that they have to handle so many things with the disease and the medical appointment and everything, that it's not maybe upfront, but definitely a space that deserves more attention.
Yeah. And it's so interesting because there are things that, I guess, from the well-being space that I've never heard of, things like dignity therapy, which I'm not sure if you're familiar with, but for people who may not have heard about it, who are listening, it's this idea of walking. I mean, I don't know it 100%, but it's about walking through your life and finding the sources of meaning and purpose and the highlights and the lowlights, and almost creating this sort of life story legacy to pass on to those, like to your loved ones. And it's full of probably optimism, of meaning and purpose, finding moments and drivers of life satisfaction. But it's ironic that they've kind of come to the same place. They just don't use the same words as us.
Mm-hmm. Yeah, absolutely. I'll be interested to hear what you find with this.
Yeah. Yeah. So the pilot should be coming out soon, hopefully, but we'll wait and see because it's publishers and editors and rejections and all that kind of fun stuff. And so on the topic, I guess, of the words that we use and the different words that we use, that I think is a nice segue into the debates around wellbeing measurement.
Mm-hmm.
And I was really interested to see your name listed amongst this kind of forwards and backwards between different academics arguing over or discussing, however you want to call it,
Mm-hmm.
over how best to make recommendations on measures of well-being, knowing that the field is a little bit of a mess, and there's this trade-off between being sort of pragmatic with what we've got versus being, what would you say the other side of it is, aspirational of what we should have.
Mm-hmm.
Our team have been working on this. We've just published a preprint on sort of a set of item banks for 19 dimensions or 25 dimensions of mental well-being, or we're calling it positive mental health. And you've been on a very similar journey. So I'd love to hear the challenges that you've come across in accurately measuring well-being, I don't know whether you sort of frame your work within psychological well-being specifically or well-being in general. I'd love to hear that. And how do you think resolving that challenge could help advance our understanding of its impact on health behaviors and health outcomes?
Yeah, so I'm glad you're referring to this scientific debate, as I like to call it in front of my student when I talk about this, but the scientific exchange we had in preventive medicine about well-being measurement. And I think actually this is how we got connected to each other, because you were interested in this debate. So I think overall, we all agree that single items are not the best. Using just single item, it's probably not the best. And that's kind of the continuity in all these back and forth. We agree to disagree on certain things, but overall, I think we agree that single items are not the best, especially because certain construct of psychological well-being are probably a little bit too complex to be captured with one item, right? I think the argument that can be made still for a single item is sparkling interest. And I'll give you two examples of this. One is that sometimes I work as a consultant for a research team who are interested in psychological well-being, but they don't work in that space specifically. So, we hear more and more about like optimism and happiness, and it's something that is really more in the science than it was before. And sometimes people are doing like psychotherapy research or other research on different construct. They come up with the idea that, maybe we should look at these things too. It seems like it matters over and above like the stress markers. So when I join this team, I will make my recommendations of different measures for psychological well-being, depending on the dimensions they're interested in. But when they start really in I'll say a newbie way and they don't know much, sometimes they don't have a lot of space to devote to. And I think this is a reality that we face a little bit more in the public health and in the epidemiology world versus the psychology world, where all the researchers, they all want to have their part of like the blanket, as we say in French. So they want like nutrition, they want like medication stuff. And so you have space for one or two or maybe three items, but not more. And then the decision is, well, maybe it's worth doing it rather than not using it at all, just to spark the interest and kind of explore association that could exist with social markers, physical health markers, regardless of the focus of the work. So when I do this consulting role, I'll suggest multi-item measures, but sometimes because of space constraint, as I mentioned, sometimes it's time constraint. I had a research team where they did interviews with all the participants on really different constructs. So you cannot arrive with like your 20-item psychological well-being measure, but they still want to have a little idea of how it behaves with their construct. So that could be another setting. And maybe another example, if people are working with like specific populations, so elderly, where like the cognitive attention cannot be sustained for a longer period of time, or so you see there are different settings where a single item could be not ideal, but you can still use them specifically for a construct that we think are not too bad when measured with one item. And I'll give the example of life satisfaction, where there's been some empirical work doing some correlation between like single item versus like 5 items or a little bit more item version of life satisfaction scales. And the correlation are like It's fine. I mean, it's not exactly the full item measure, but it does a pretty good job. So I think for certain construct, we can do it. The other thing we can think about in terms of sparkling interest is the work that has been done with the Cantrell ladder, which is not like an item, but it's a visual. But this is how we were able to capture life satisfaction around the world. This is one of the first kind of attempt to capture a dimension of psychological well-being in different countries and see whether there were some disparities between the countries. So if you want to do like really large scale research, sometimes it's the only way you can do it by being really concise. And it's the first step into something that will become larger. And I'll cite as an example, but like the flourishing scales that these days have been administered in really different countries. And then we can start doing like cross-cultural assessment of flourishing. Like it's been really interesting to see this unroll. Mm-hmm. But sometimes we need to start really smaller to just get the interest kind of rolling. So I think in that scenario, I would argue that single items are better than nothing at all, just because it brings more after it. This is how science evolves anyway.
Yeah, and I'm wondering, as you're saying it, I'm wondering whether it's like the problem is more in the reporting, in the sense that whether it was a 20-item scale or a 1-item scale, we just call it optimism. And so we sort of introduce this confusion basically in the literature because we just act as if it's the same. And we know that it's not. And I think you've just laid it out in a really pragmatic way, which is we want to have just a slight indication just to see if there's anything in a very exploratory way, then we should call it whatever, like exploratory optimism or just even one item optimism or whatever we call it. Just so that we don't confuse, because I think that to me seems the biggest challenge is that people write these things, like they put them in their studies, they publish, they put them in the abstract, all with the right intentions, just like what you're saying. But then somebody without that context picks up that study and says, look, optimism does this amazing thing, maybe not recognizing that it was based on, a single item and therefore has that limitation.
Yeah, absolutely. And this has like, I will say, trivial consequences in terms of, and we have an example in our own work where we looked at the relationship between optimism and hypertension risk over time. And I'll say just upfront that these were two different populations. So difference in results could be due to the fact that it was two different populations. But in one study, we had the LOTR, which is like one of the most widely used self-reported measure for optimism. And in the other study, we had a single item that was part of many other questions. And in the study where we used a single item, we found no association with hypertension incidence. And in the study where we had the multi-item scale, we saw an association. And again, it could be due to the population, but I think it becomes tricky in terms of the conclusion we're doing, because do we see that optimism is not predictive of hypertension risk? Is it because there's really no association, or it's because the measure itself was not nuanced enough because it was a single item to capture this construct on its own? So I think we need to be really careful, as you say, like saying upfront, we explore, it's a single item measure, that's probably not capturing everything in the complexity of this phenomenon, but so far this is what we find, just in terms of making accurate conclusion.
Yeah, that is such a perfect example. That's awesome. I'm going to be citing that very often now, because it's like I think the biggest frustration is inconsistency. I think to me that's the problem, and there are a million constraints of why we are inconsistent. I will put my own hand up and say I've called it every name under the sun: well-being, mental well-being, positive mental health, probably other variations of that. I had someone messaged me and saying, why is an Australian spelling well-being with a hyphen? And it's like, well, that's what the journal tells you to do. So that's what we do. There are all these limitations on word count and all these things. So I'm with you there. That's very cool. And so I think you've probably actually answered that second part of the question already, but I just want to make sure that you had anything else to say on it, which is how would resolving some of these challenges advance our understanding of the impact in health behaviors and outcomes? I think you've probably answered that in the sense that clearly measuring these things robustly gives us the best chance of answering these things accurately.
Yeah, exactly. So kind of in the accuracy of the conclusion you're making, is it because there's no association and it's not worth pursuing from a clinical perspective? Or is it because it's not measured accurately and then we're missing an association, which is totally two different stories, right? But I think the other kind of hot topic in measurement is also the cultural sensitivity of measures. And I'll see another example about this, or another story about this. As we know, most of the measures, they've been developed in like university students, weird population. So it's a great start. And of course, I'm not downplaying any of the research that has been done before, but now we need to move beyond that and move a step forward to see to what extent these measures are really capturing what they want us to capture in different population. And a couple of years ago, we did a bunch of studies looking at the role of optimism in different health outcomes. So are optimistic people living longer? Are they more likely to be exceptional agers? Do they not only live longer, but live healthier, so be like healthy agers? And we look at this in different population in the US, and the associations were robust. Like they were there controlling for everything under the sun, including depression. But then we did a study in Japan where we looked at optimism in relation to longevity. Nothing. Using the same questionnaire that like all the study used, or nearly all the study used, and there was no association whatsoever. And we were just like, this is so interesting, like because it's been so robustly and consistently associated with all those health outcomes in our prior work. And one of our team member was from Japan, so we started this conversation about like, what do you think about this? And she just brought up the idea that it's not as well perceived or encouraged to be optimistic, essentially. So the perception of optimism is not as valued over there as it can be here. And I think this is just a really nice example of not finding association. Really could be because there is no association, but maybe because it's a construct that deserve the assessment really accurately, either in terms of measure to capture complexity, or accuracy in terms of who are you working with? Who are these people? What are their set of beliefs and perception about different construct of well-being? Is it something they value, they understand the same way we understand it? So there are so many questions about the cultural adaptation of those self-reported skills. And I think that if we're not right on point on this, then we can make some wrong conclusion about what we
And I mean, there's so much there, isn't it? And I do wonder whether how much limit, like, there's not much funding available, I think, for these kind of I wonder where the limitations come from, because I don't think many academics disagree with what you just said, except we just kind of do continue with kind of business as usual. I take my scale, I take it over there, maybe we translate it. But doesn't seem to be that much of an opportunity to sort of push into these questions so much. Maybe that's a growing part of the field.
Yeah. So upfront, what I'm thinking, there is the Stress Measurement Network in the US who has been interested in funding kind of pilot studies. And what I can recall, it's more like comparing different countries on the mental physical health association. So it's not exactly like development of measures, but I think they might have had a call about like more measure development and cross-cultural validation. Okay. So maybe that's something to look into. And I'll have to say, for ongoing work that I have, and that maybe I'll speak to another episode, but sometimes it's just labor of love. Like we work on this, we don't have any funding, and it's really slow process, but yeah.
Yeah, I just had Sarah Willen, the anthropologist, on the show. That episode hasn't come out yet, but she's critical of the Global Flourishing Scale survey. Sorry, for those questions, because it's such. And I can see it both ways. It's an ambitious project, and no one will deny that. And it sounds like a lot of pre-work has gone into trying to do these things, but so many countries, so many questions. I think this speaks probably to the heart of that balancing act that we just spoke about, of the sort of the sparkling interest versus the sort of the fully rigorous work. And I met someone at IPA who was really interesting, and he was telling me about his work, and actually I remembered the work basically because I just read it, and it was in a Kuba Chris article about some of this cross-cultural work. And the article started with a quote, and the quote came from this gentleman's work, which was, him interviewing an older Japanese man, funnily
Mm-hmm.
enough. And I think the quote was something like, the question was like, are you happy, or something like that? And the man's response was, why would you ask me that? What a weird question to ask me. I've never
Mm-hmm.
thought about that once in my life. Am I happy? And I thought that was like, that's such a good way to start that article, basically.
Yeah. Yeah, absolutely. Like more broadly, I think, of course, there are like ideal ways of doing measurements and some approaches that have clear limitations, but I think we need to also bear in mind processes in science about replication, triangulation of results. So I think like it's an ongoing effort, and it's an
Yeah.
ongoing effort from different teams. We're not working against each other, we're working with each other and trying to like make it as accurate as possible, but it's through that these kinds of like scientific processes of replication that we'll get a clearer
Yeah.
answer to.
Yeah, very cool. And so I want to ask just one more question before we go into your work on coping, but just in terms of that back and forwards of this academic discourse, or academic rap battle, whatever you want to call it,
Mm-hmm.
how productive, like what did it feel like to be involved in that? And like a part of me wonders, and I think I've posted about this a few times, like a conversation might be more valuable than this unraveling kind of discourse that probably takes 2 or 3 years, by the
Mm-hmm.
time that each team has kind of published and then responded again. Do you think it was productive, and how could it be even, faster, basically? Because I think we want to get to some of the answers to these questions as quick as we can.
Yeah. Oh my, there's so much to say about this, but yeah. So we have a book, an open access book about well-being measurement, and it's not only psychological well-being, but it's well-being overall. So we have like spiritual and community. There you go. Thank you. And this book unfolded from, I think it was a 2-day workshop where we gather folks. When I say we, I talk about Harvard colleagues, and more specifically Tyler Vanderweel and Laura Kipczynski, where we gather folks from different backgrounds. So economics, philosophy, psychology, public health, and everybody was sitting in the same room. And we talked a lot about well-being measurement. So I think that's kind of a great way to have this conversation flowing at a faster pace than doing one publication, especially with the rhythm that it takes to publish one paper and then have a response from someone else. And we had this book and then some papers following this workshop. So I think that's a really great start to get the conversation starting.
Mm-hmm, mm-hmm.
And then after, how was the process? I have to say, and this is really because it's conversational, but I was so shy of like having a scientific debate with Carol Riff, who I respect a lot. And, as I said, when I started this question, I think we all agree that single items are not ideal. So when we had this back and forth, I was just like, oh my gosh, I cannot believe I'm arguing scientifically with Carol Riff. But she had a great point, and I think it's informed also our background and how we came to this space. I did the contrast of life psychology versus public health, which has we have different challenges when we're doing our research, but it's been humbling to say the least to have this debate, but really informative because, as you highlighted, the debate and the conversation goes really faster. So you need to be on top of your toes to like think and respond and have your good argument, which we had before publishing this. But so it's been really instructive for me as a scholar, as a thinker. And also I love presenting this in my teaching because I think it shows a really different facets of how scientific think about issues, pressing issues, and how they react to what is done.
Mm-hmm.
And how they can have a conversation where people agree to disagree. It's still respectful, but it helps move the science forward.
Yeah, absolutely. I guess my question is really like, can we speed this up? Because I think I fully agree with what you're saying, and I know that probably people do need the time to sit and think and carefully write out their response. And and I say, having me on the other side of the world, having read through the forwards and backwards, benefited a lot from it. But I also had the luxury of finding it once it had already come out. if I just found the first one and then had to wait a year and then another year and then another, like I think it could have been lost. A part of me wonders whether, like, semi-selfishly, podcasts can be the way to bring forward some of these conversations faster, but obviously it doesn't come with the careful thought of the forwards and backwards. So what do you think about that?
Yeah, well, I think you did a debate on well-being, so I think that's a great spot. I think another place where it could be done is scientific conferences, because typically you're attracting people who are interested in similar topics. I remember one of the conferences I go to pretty regularly. At some point, we planned a debate about, I think it was actually, it's a couple of years ago, but the value of psychological well-being over and above removal of psychological distress. So one part was arguing that, once you end all anxiety or depression, your job is done, versus the other part was arguing, well, there's more than that to be done. So I think that could be a great spot, because you have this debate and then you have people in the audience who can chime in and like nourish the conversation. But then you just have to take care of like the following steps. So are you kind of summarizing this in a paper to publish so people can have access when they were not attending the conference? So yeah, that could be a start of a new way of doing things.
Yeah, I really agree. So that's really cool. Very cool. All right, so that's my personal interest out the way. Now let's get back to your topics. To go forwards from here, I think the other part of your work that we haven't really described is this overlap with coping, emotional regulation, resilience, and well-being. And so I'd love to start with a common misconception. Are there any misconceptions about these concepts that you are frustrated with that you'd like to clarify? Because I would quickly jump in that I think I've been in this world for maybe 10 years. And at the start, resilience was a big thing. Like, let's build resilience. And then, a few years later, people have been misusing these words. It's become I think there's even an article that says like resilience is a dirty word or something now, which is because it's like, if it's a very finger pointing thing. Like, if you're feeling stressed, that's because you're not resilient. You need to toughen up. I don't think that's how anyone in the academic literature or yourself mean what they mean when they say resilience. But so I'd love to hear your take on some misconceptions here.
Yeah, so I love this example because it loops back to the guilty part that I was mentioning earlier. And really, that's not the goal. Resilience is more about functioning better than what we could expect if the person is facing some kind of like important adversity. So this is where we'll see people are more or less resilient. And in my work, where I'm really interested in the intersection between mental and physical health, essentially I'm hoping to help and contribute efforts to make people more resilient from the mental, but also the physical health standpoint. And that brought me into the coping and emotion regulation space, because these are some of the key mechanisms of resilience, right? So if people are facing stressors, what makes person A feel better afterwards than person B? Well, maybe some of the answers are that person copes more favorably with stress. Maybe that person regulates more adaptively their emotions. And this is one of the paths that brings these individuals to resilience. So I've been really interested in these two kind of theories and framework that, as you may know, have evolved really separately for many decades. We have the coping crew and we have the emotion regulation crew.
I didn't know that.
Yeah, really. And I mean, they are distinct clearly conceptually for many reasons. The coping is really associated with the stress construct. So you need to feel stress. You feel like your environment is asking you things that you cannot reach in terms of dealing with a stressful situation. And people can cope with stress in really different ways. They can have like emotional, but also more behavioral strategies to cope with stress. And I'm happy to give a few examples later. But versus the emotion regulation piece is really about how you regulate your emotions. So it's really like short term, there's no stressor. You can regulate positive, but also negative emotions. So there's the positive part that is not in the coping space. So these are really different constructs for these reasons, but also they have similarities. Like it helps people typically in a fairly deliberate way adjust to their environment. So cope with stress, regulate their emotions. And in both literature, when they look at the different strategies, they will say, well, X, Y, and Z strategies are fairly adaptive and A, B, C strategy are fairly maladaptive. So this kind of classification of adaptive versus maladaptive is also reported in both theories. And so recently, there are other scholars and really leader in the fields of emotion regulation, such as James Gross, who said, well, maybe we should bring them together under the affect regulation framework. And this is a fairly recent paper, but George Bonanno and others have talked about the similarities between these two constructs. And I was really puzzled about this. I was starting to think about this idea for a little while. And what we did in complement to that, because most of the work thus far compared those two framework or theories really from the conceptual standpoint. And having my measurement hat, I decided to do the exercise, but really with the measures of coping and the measures of emotion regulation. So maybe after our conversation, you'll have the emotion regulation in your taxonomy of positive mental health, or maybe we can talk about this if you want to do this exercise. But essentially, we published recently in Canadian Psychology a review where we conceptually contrast those two theories with, of course, similarities, but also clear distinction. But we compared the measures. And I have to say, Matt, it was even more mind-blowing than I thought it would be in terms of...
I'm wondering how many people would say, like, associate the word measurement and mind-blowing in the same sentence, but I love it. Very cool. Tell me about it.
I'm sure we can have a couple of anecdotes for that. But of course, some items are really different. But if you think of like positive reappraisal, which is a coping strategy, and then positive reinterpretation in the coping world, and then cognitive reappraisal in the emotion regulation world, like this, the items are really similar.
Yeah,
and there are a couple of others that are really similar. And I think thinking about them under this affect regulation framework really makes sense in terms of like research implication, because you just have access to more strategies. Regardless of if you're interested in like what are the predictors of these strategies or what are the outcomes, mental health outcomes, physical health outcomes, you just have a broader toolbox to get from. So if you're using existing data, there are more stuff you can look into. So I think it's interesting for that reason. Clinically also, like if you want to help people better handle their environment, their stressor, adversity, emotion regulation, you don't have to stick with like coping literature, or you don't have to stick with emotion regulation literature, and you can combine those together. And then the argument is that as they are key mechanisms of resilience, we can have more options, if I can say, to try to understand what makes people more resilient. So that's kind of a big overview of like similarity and distinction, and perhaps the argument of considering them a little bit more closely together. The other thing that is really interesting from that work is going back to the adaptive versus maladaptive nature of strategies. And again, everything that I'll say, it's not me who brought this. Like many scholars have talked about this before, but we know that some strategies are typically more adaptive, like doing problem solving or trying to see a stressor with a different light, like doing some reappraisal. Typically, it's associated with better mental health outcomes, even better physical health outcomes in more emerging research, versus other strategy like denial or suppressing your emotion. Typically, it's not seen as being as adaptive. But there is really the missing piece of like, what's the context? Because some strategies in certain contexts could actually be good. And here's my favorite example, okay? Suppressing your emotion. Typically not a good thing, right? This is not what we would call an adaptive strategies. But I can assure you that if you're speeding on the highway and you get pulled off by a police officer for a speeding ticket, you might as well suppress your anger. This is not a good time to express your anger, right? So there are, and this is kind of a little funny illustrative example that I like to give to my student, but this is really showing like certain strategies and certain contexts could be good. So depending on the context, we need to have this kind of sensibility or attention to context, and also timing. So looping back to from our health psychology example, if someone received a cancer diagnosis, perhaps denial or distraction for the first few hours, the first few days, it can help handle the distress, the reaction, the emotional reaction to it. But certainly we wouldn't want that person to only use distraction for the next few weeks, for the next few months, for the next few years, right? So the timing, also the context, but also the timing of is really key, rather than just saying, this is adaptive and this is maladaptive.
I think so we do a lot of wellbeing training, and we were working yesterday with prison guards, basically. And I think I would have said almost exactly what you just said. So we have so much similarity, because we talk a bit about avoidance as an unhelpful strategy, and this idea that, just as you say, it comes with immediate relief, but it's not effective in the long term. And always people give pushback on that, which is kind of welcomed, but sometimes you need that immediate relief. And absolutely. And I think that probably does speak to something that you're saying across many of your studies, even back to the very first stuff we talked about, which is that, like you say, things that we find in the research world are adaptive in general. Mm-hmm. And it's a misinterpretation of those findings to say that it is 100% adaptive. And yet that's sometimes, again, a misinterpretation of the data, where we say, this is associated with this, let's do it all the time.
Mm-hmm. Yeah,
it's so interesting. And so where will, going back a few steps, this idea of bringing together these different models, because again, we're on the same journey of starting with measures, trying to look for unique aspects, basically, because we don't need different theories. We don't need overlapping theories, basically. We need to get to the bottom of it. And if we're calling the same thing, or if we're measuring two different things with the same items, that's just a problem for us we need to solve. Where would this land? Where do you hope that this ends up, this kind of mapping of the two models into one?
In terms of well-being and more like the affect?
Well, yeah. I mean, what's your hope for clarifying? If I'm understanding correctly, your aim is to sort of clarify the literature a little bit.
Mm-hmm.
Where to from here?
Yeah, well, probably so many things, right? So many avenue we can take. I think one thing that, having been like trained as a clinical psych and then spending so much time in public health and social epi, I think there's something really nourishing to go from one discipline to another, or to have this kind of crosstalk. Mm-hmm. And I'll give one example of that. So lately, we've been doing a lot of studies looking at those adaptive and maladaptive strategies in relation to long-term health outcomes. So really in a social epi framework. And as expected, our research will show that people who engage more regularly or more frequently in more adaptive strategies, they live longer. We have one study where we saw that people had a 66% shorter lifespan when they were using more denial or behavioral disengagement, and 6% is like 5 years. So, I don't know about you, but in 5 years, I do quite a lot of things. So that's kind of substantial after adjusting for, everything that could kind of matter under the sun. We looked at this with health behaviors. So we have like really ongoing efforts to look at the predictive values of those coping and emotion regulation strategies with long-term health outcomes. But as I said, this is a really social epidemiology framework in the way we think about things, and using these long-standing and large data sets, which really allow that kind of research question. But we were puzzled from the get-go with this kind of tension of like, is it really 100% adaptive, or is it really 100% maladaptive? And this is where I see like crosstalk between disciplines. We went back into the psych literature, and for a while there were some folks doing research on like coping variability or coping flexibility, and emotion regulation variability and flexibility. So we pull that in. And we do this in nearly all of our studies, where we look at the adaptive, we looked at the maladaptive strategies, and after we look at the coping variability or the emotion regulation variability. And in a nutshell, it says to what extent people are flexible with these different strategies when they're facing a stressor, when they're trying to regulate their emotion. And it's a numerical index. So it's not like we have videotapes of how people behave in different contexts, which would be ideal. So I think that's one of the ways to move forward, is to continue this conversation between disciplines And the parallel is the same when I said we sat with philosophers to hear about like what's their view of eudaimonic well-being. How should we measure eudaimonic well-being? Are we doing the best that we can, or is there other ways we can think about this? So I think really richer conversation and research questions and projects and methodologies can unfold from this kind of crosstalk. And in the paper where we contrasted the measures between coping and emotion regulation, we also talked about the interrelationship between all of these constructs, partly saying that sometimes in large data sets you don't have access to coping or emotion regulation, but we know that if people regulate effectively or if they cope effectively, probably they have a little bit less distress, a little more well-being. So these are not perfect proxy in any way, but like just keep that in mind as we're moving the science forward and trying to integrate these different constructs of mental health and eventually like leading to optimal mental health functioning.
Yeah, and have you ever looked at sort of the Lindsay Odes and Uni Melbourne work around wellbeing literacy? Because I'm just thinking that so much of the way that they've framed up literacy is about, and I'm totally butchering their work probably, but the using the language of well-being in a way that is context specific. And just so many people around me are, migrants from World War II, basically to Australia. So from a range of different European countries that have come here, my grandparents and my friends and whatever. I do think that we maybe look at people that were more directly affected by the war, say, and the migration experience, who maybe do carry some of those things that we would consider maladaptive, denial, avoidance. They might have been useful in that context of those early years of coming to another country, facing racism, coming here with nothing, all these kinds of ideas. But now as 80-year-olds, they're not necessarily required anymore, or they're not adaptive anymore.
Mm-hmm.
So I'm really interested in this idea of sort of how do we snap people out of what might have been a useful formula that might not be useful anymore because the context has changed around us, but we're sort of stuck in autopilot, that kind of idea.
Yeah, I mean, I cannot speak to this directly. I don't know that literature that much, but I think it's super interesting, and it's kind of a good segue or connection with one other point that I've been really thinking about is how these processes, these regulatory processes that leads to resilience or not, how are they distributed across different subgroup of the population? And I think a little bit related to what you brought is across education level, for instance. And in one of our paper, just to give you an illustration of that, we found that reappraisal or reinterpretation, which is really a cognitive way of like seeing a stressor and changing the way you approach it or think about it, had detrimental impact in people who were less educated. Whereas typically it's seen like an adaptive strategy, right? And there is this whole body of literature saying like some ways to cope with stress and possibly regulate emotion maybe are not as adaptive in people, different subgroup of the population for a different reason. So in that specific example, we can think that maybe people with a lower education level, they're less used to do some reappraisal because it's really cognitive. So maybe you learn more to do it with education level and perhaps have less opportunities. Or maybe folks in this kind of lower SES group, they have barriers in their environment to learn how to reappraise. Maybe they are as good as more educated people, but they didn't have the opportunity to learn about it. And then when they try to implement it, it comes with a cost. And as I said, there is some literature about that. There is the John Henryism phenomenon where we looked at how people cope with stress, and we saw that there was some downstream negative effect on their health for that. So I think we need to be really mindful of like where people are coming from. So I'm not directly answering your question, but I think it's kind of a parallel example of maybe they don't have the resources to learn how to cope or to regulate their emotion. And maybe some strategies that typically we think are good for everyone, maybe they can be good, but they come with a cost. or they're not as accessible for a certain group of the population. So I think we need to be really mindful of this, both when we think about predictors of these coping, regulation, and even well-being construct, but also when we think about the downstream effect on mental health, physical health. It's not a magic pill across the board for everyone in every context and with every background.
Yeah. Thank you. That's awesome. And so I have one last question for you. Thank you so much for your time. This has been so interesting. I'm just throwing one out randomly now, but it's so common to hear, young people aren't resilient anymore. I think we were talking about at work, someone, I don't know whether it was someone's grandparent or whatever it was, someone said, I think they went out, someone did some work in a rural area in South Australia, and they said, young people, they're just pathetic. They're pathetic now in relationship to their resilience. Like, what's your response to that kind of cultural narrative that we've got at the moment, that young people are just so not resilient?
Yeah, that's a big question. I don't know.
Okay.
I think I would say, let's think about the drivers. And again, I'm bringing this kind of like more contextual, societal, structural forces that drive how people regulate their affect, but also their well-being. There are so many changes, political tension, climate change crisis. There are many things that are known to influence mental health. So we can imagine that for these younger generation, these are all different forces that are coming into play that maybe older generation, they had their stressors, don't get me wrong, but I think it's just like a really peculiar time and space to be in. And also the way we think about, for instance, what's the purpose in life is really different. Like if you go back a couple of generations, it was like the work, the family, making sure everybody was fed and had a roof on their head. Maybe now it's really different. What brings purpose in life to these younger generation, and it might be harder to find. And even someone who like thought that they would be really devoted in their work, for instance, and that could be their purpose in life, well, their market is changing, the economy is not going well. So I think there are really different challenges these days than before, and that might contribute to this kind of lack of direction and a little bit less like emotional vitality and zest. So I think it's a good challenge for us as scientists, but also as clinicians, to try to see like how can we find a path to increase well-being despite all of these stressors and adversities, and with something that resonates with that population, which is just really different than prior populations.
Perfect answer. Thank you very much. And so context, basically. Mm-hmm. Very cool. Well, thank you so much for your time. Is there anything we haven't covered that you wanted to talk about?
I mean, we talked about a lot of things already.
Yeah.
So maybe there will be a follow-up, but really it's been a pleasure, and it seems like we could continue this offline conversation as well. But thank you for having me, Matt. It was really
no worries. No, my pleasure. So thank you very much again. And where can we find you? Where can people connect with your work?
Online. Everything is online, but my team in Quebec, we have a Facebook page, a Twitter/X page. We are on Instagram. So all the social media, it's FITZ, FITZ, Lab, LAB, UQTR, which is the acronym for my institution. But if you look for FITZ Lab, you should find us online. And otherwise, I'm on LinkedIn, ResearchGate, all those
things.
Typical things.
Very cool. Well, thank you very much. Really appreciate your time.
Thank you.